And tribal organizations, local agencies, state agencies can apply for them. It's not open to the private sector. Next slide. So the goals of GusNIP is to try to improve the health and nutrition of SNAP recipients. And they want to do that by incentivizing the purchase of fruits and vegetables. In most of the projects, we'll talk a little bit about how those projects differ from place to place, but in most projects, what we see is the incentivizing of the purchase of fresh fruits and vegetables. The goal is to try to reduce household food insecurity and nutrition and increase their nutrition security. We want to improve the health outcomes of participating households and decrease healthcare costs for those folks. Next slide, please. So what does it look like? There are two distinct kinds of programs that are authorized by GusNIP. The first one, and it's predominantly the one we see in most places, are nutrition incentive programs. By that, what we mean is somebody needs to go into a store or farmer's market or wherever the participating outlet is and make a qualifying purchase. And if they do that, they get an incentive to make another qualifying purchase. The second kind of program is a produce prescription program. And in that situation, someone is diagnosed as having health issues that could be improved by the intake of healthier foods. And if that happens, then the person is given a benefit to be used for the purchase of healthier foods. There's no qualifying purchase that's needed. As I said, the project works in traditional grocery stores, corner stores, mobile markets, farmers markets, any place that's authorized to accept SNAP benefits. And the programs can look different from place to place. Next slide. This slide, I'm not going to spend a lot of time on, but if you access the presentation afterwards, it gives you a breakdown of the differences between the SNAP produce incentive kinds of programs and the produce prescription program. Next slide, please. So how do they work? So I mentioned in the nutrition incentive side, the person who's participating needs to make a qualifying purchase. And those can be set up in any of three different ways. If somebody comes in and buys the produce that's deemed eligible, they can get an incentive for more produce. If they purchase the qualifying produce in a different design, they get an incentive to make purchases of any SNAP authorized foods. And on the flip side, in some places, when you come in and make a SNAP purchase with your benefits, you get an incentive that can only be used on the qualifying produce. So what can you buy? Like I said, the definition is pretty wide open. It can be fresh fruits and vegetables. It can be frozen. It can be canned as long as there aren't additives. Like added sugar and added salt to those products, or the project director and the project design can narrow it down so that it's only fresh fruits. It's really up to the design of the project as to how they want to do that. In a nutrition incentive program, there's a matching requirement. So if you're interested in applying, you have to come up with a dollar for dollar match that the federal government will give to you. So if you wanted to, say, do a $500,000 program, you'd have to come up with $250,000, and the federal government would match that with another $250,000. One of the other kinds of things that we see in projects is local and regional sourcing. We know that in a lot of communities, the groups that are applying for these projects would like to use them as a way to boost the local agricultural economy. And this is one way that they can do that, so that the qualifying purchase may only be for local produce, or you may only be able to use the incentive that you get for local produce. Next slide, please. Produce prescriptions, as I mentioned at the outset, are distinctly different. In here, you don't have a qualifying purchase. Someone is deemed nutritionally at risk, and therefore they get a benefit to try to improve their health by incentivizing the purchase of healthy foods. SNAP participation is not required. You can limit a program to focus only on SNAP, but you can also allow for folks that are on Medicaid or people who are eligible for Medicaid or eligible for SNAP, even though they're not receiving it. There's no matching requirement in a produce prescription program. So you don't have to come up with money that the federal government matches. If the project is approved, a grant is given to the applicant and they can use that money to go ahead and provide the benefits. But it does require a health diagnosis in order to trigger the benefits to the participant. Next slide, please. So let's talk a little bit about the Nutrition Incentive Hub. Along with funding these projects, Congress also funded the establishment of a technical assistance center called the Nutrition Incentive Hub. And the National Grocers Association Foundation is one of many different partners that have received grant funding to be able to provide technical assistance to stores, to grantees, to applicants, to any of the folks that are involved or are interested in being involved in GusNIP. It's a free service that anybody can reach out and get. Whether you may be talking with us, you may be talking with some of our partners. Next slide. This slide shows you who some of the different partners are. There are evaluation requirements associated with projects, and so there's help that's provided for that. There's technical assistance provided for the design and the standing up and the operation of projects. We tend to, at the National Grocers Association Foundation, we focus on brick and mortar grocers. There are other partners that are involved in the Nutrition Incentive Hub that can help you out if you're more involved with, or if you want to look at farm direct, farmers markets, and those kinds of outlets. Next slide, please. And as I said, what we are doing is trying to facilitate the implementation of the projects. We're doing that in two different ways. We are sort of a matchmaker. If we know of a grantee or a prospective grantee that's looking for stores that they'd like to partner with, we'll try to help you out. Likewise, we're also talking to stores who are interested in trying to find grantees and projects that they can participate in. We've also been doing a lot of work on the technology side, trying to make it smooth for the implementation of these projects. So we've been working a lot with companies that provide equipment and software services to stores to try to do that. Now I'm going to turn this over real quickly to the folks who are on the ground, who have been doing this for a while and have been having a great success trying to help folks who are in need. Next slide. So Kymie, you're up.
Hello, everyone. Good afternoon. My name is Kymie Thomas. I'm the program supervisor here for the Navajo Fruit and Vegetable Prescription Program. The Navajo Fruit and Vegetable Prescription Program is based out in Gallup, New Mexico. We serve the primary population of the Navajo people. And it's nice to meet you guys. Thank you again for inviting me to share a little bit more about the program and how we've really tried to increase access to healthy foods for families, and also, monitoring some of the health outcomes associated with the program implementation. So hopefully this is more, informative and, can definitely reach across to other tribal communities as well. Next slide. So just for some background context, the Navajo Nation spans across 3 states, one of the larger Native American reservations in the US that has a land base of approximately 27,000 square miles. And, just for some more background, there are fewer than 15 grocery stores that are located on the Navajo Nation. Most of our families that participate in the program, or, just families in general looking to buy groceries, often travel an hour or more to the nearest grocery store. And, like I said, most of the time it is off the reservation. So we do have border towns we consider, or we call them, that most of the families often, spend their money at and try to obtain their groceries in that way. Families that are living on the Navajo Nation face food insecurity rates that are 5 times the national average. And so the co-program is a nonprofit organization that serves this community. And we, work across multi-regional areas. So again, like I had mentioned, Utah, New Mexico, and Arizona. And so we operate under quite a few grants that help to support the program so that we can deliver it in different regional areas, but still serve the Navajo population. Next slide, please. So the overall program, the COPE program, is actually designed to assist in like public health initiatives and really to tackle some of the disparities and some of the challenges and barriers that are faced on the Navajo Nation. The COPE program is a nonprofit organization. And so, within that we work collaboratively under several initiatives. We have our Healthy Navajo Stores initiative, which Robert will be able to talk a little bit more about. And then our Growers initiative, which kind of connects us to, allowing our participants to purchase items with local growers. And so we work under the umbrella program of the Food Access Program. And so there are other initiatives going on within the Community Outreach and Patient Empowerment Program that, also assist in other initiatives across the Navajo Nation. But for, the overall mission of the organization is to really invest into the current resources that we have and, sort of base them with and alongside the historical health inequalities that lie in Native communities themselves. And then really investing in, like I had mentioned, the community resources and aligning our work with, the help of our tribal leadership, community members, and, the people, community in general, to help us transform, the vision that we seek so that we can improve health outcomes for our Navajo people. And so, really, it's a collaborative project that we're all working on to see, increase health outcomes for our Navajo people. The goals of our program, specifically the Navajo FVRx program, are to increase access to healthy and traditional foods among Navajo families. Through GusNIP, we were able to obtain additional funding for our participants. And, the unique thing about our program is we also really try to incorporate the traditional food aspect. And so, developing materials, presenting materials, and really integrating a lot of the traditional knowledge of food that is, specific to this community. And so, that's, I think, the unique thing about our program. We also increase the consumption of healthy and locally grown fruits and vegetables. So, as I mentioned, really trying to integrate the partnerships and collaborations that we have with our local growers. Of course, improve health outcomes in people affected by diet-related diseases. And then also, as mentioned before, to stimulate the economy and promote local sales of healthy foods on the Navajo Nation for our community members. Next slide, please. So how does the program work? So the program vouchers are distributed for purchase for fresh and healthy traditional food items. With our participants, we use the concept of food is medicine. So cultural foods are really included as part of our acceptable items and can be purchased at our local participating retailers. We offer the nutrition education component in order to receive the vouchers. So we try to find culturally relevant health education materials to deliver it to our families, because as you know, some of the nutrition standards across the US are actually different than what is relatable, I guess, to our Navajo families. And so we've had to modify and tailor education materials to meet the unique needs of the people, living on the Navajo Nation, and, that would also work in tribal communities as well. So families redeem vouchers with local stores and farmers markets on the Navajo Nation. And all of this is done through a collaborative approach that we have with the existing healthcare facilities on the Navajo Nation. Right now, we work with 11 healthcare facilities. Prior to COVID, we also worked with early childhood centers. And, due to the disruption that COVID had, we weren't really able to see the impact with implementation at an early childhood center. We also use home visitation services prior. And, we've tried to find multiple avenues to implement the program, but most of the work that we've been doing has been through the clinical side, through Navajo Area Indian Health Service. And then also, really kind of looking at how our community partnerships are crucial to the success of the program. So, creating those outlets of networking, within the program has really helped us to modify it so that it's uniquely tailored to our program here. And then, of course, having a motivated healthcare team is essentially the bigger piece of the program, because if we don't have a motivated healthcare team, then it's really hard to get the program started, implemented, and to have the dedication and teamwork needed to make this program work across, with our participants. Next slide, please. So the participant eligibility requirements are extended to our pregnant moms and postpartum moms up to 1 year. It says 2 years, but up to 1 year. And then children ages 0 to 5, or if they're under 6 years of age, might be a better gauge. And then adults, we recently expanded and were awarded a grant to include adults with chronic conditions, which is actually a new project that we're working on. We haven't really worked with adults with chronic conditions outside of our maternal and pediatric cohort. So we're really excited. There has been a lot of support and a lot of interest among our clinics about implementing with the adults who have been impacted by COVID and have, chronic conditions. Some considerations for the development of our team and really, figuring out how we're going to implement the program, who's going to participate is really based on, the area that we're serving, who is going to benefit from the program. Is there, clinics nearby? Are there stores nearby? And really just the capacity of the enrollment team, which is so important right now, because it isn't feasible for one person to be, the sole champion of a program like this. It takes, 4 to 5 helping hands to implement this program successfully in a way that it's not burdensome on the healthcare team. And so ideally, we kind of really want a larger team when implementing a program of this magnitude, because it is, the administrative pieces of it are, they do tend to, get weary because of the additional tasks that the healthcare providers are doing on top of program implementation. And also curriculum training and background and health education, really looking at, what kind of education material that we have that is going to be, relevant to the population that we're serving. And then really looking at the strengths of the team, people delivering the education, things like that are what we also really consider when we're looking at implementing, programs on the Navajo Nation. Next slide, please. So this is typically what the overview of what a family's enrollment looks like. The first step being, families from different households that meet our target eligibility criteria are identified from a healthcare provider or a community health team, as we call them, as enrollment. So they start the initial process. The initial process starts with them being identified, gathering baseline metrics, height, weight, some BMI, and things like that. So they conduct the participants participate in the initial survey, and that's done at the initial setting. And then participants, once their enrollment is completed, participants then attend monthly education sessions during the enrollment, which varies between different cohorts. Pediatric participants are enrolled for 6 months. Maternal participants are enrolled for 9 months. So they attend each nutrition education session on a monthly basis for the duration of, however long they're enrolled from their cohort. Once they complete the education session there, then they receive our program vouchers and the prescription. And then during that time, we monitor them, and the healthcare providers really talk about change and helping them set goals for healthy lifestyles and target measures. And then the community health teams then distribute the vouchers and the prescriptions on a monthly basis after that until their enrollment is completed. And then the participants redeem their vouchers with local retailers for our fresh fruits, vegetables, and also traditional foods if they wish. And then, at the end of the cycle, they complete their exit surveys or their post surveys. And then, we really try to see how, what the impact was, over the duration of the program. And so it really kind of, we're able to monitor and keep track of that with the teams alongside them, offering the teams technical support or really support in any way that we can. Next slide, please. So, how were we able to develop a tailored program, prescription program to the Navajo people? To create the program, COPE learned that we must identify the needs based on feedback, existing community resources, and health indicators in hopes that the initiative that we're working towards to implement is actually compatible with the needs in the community. And I think that's so important because, if there aren't any resources or really anything to collaborate with or, strengthen, it's really hard to implement programs where there really are limited resources. And Native communities in general really have already challenges and barriers with resources. And so when we were looking at developing the program, we looked at what resources were available in the communities, which population had the highest needs, so pediatric and maternal, and then also now the adult population. And then how can we help to foster a multidisciplinary approach to ensure the program is feasible and sustainable? So looking at, how are we going to collaborate with, different professionals in the healthcare field, but also, aside from the clinic, what are other resources that we can work with, the WIC program, SNAP, and things like that to really make this program work? And then how do we tailor the program to become individualized across a large geographical area that meets the needs of the community? Because I had mentioned, each tribal community is very different in terms of the resources that they have available, what kind of support they have available, what sort of policies that they have in place to support, healthy outcomes and things like that. And fortunately for us, the Navajo Nation has done a good job with, really emphasizing the importance of health and nutrition, on our tribal community. And so some of the things that we looked at were, of course, identified barriers to access to healthy foods, the prevalence of diet-related diseases in our community, as well as, what target population do we feel like, we can monitor and help assess to also, so that the program is impactful for them. So just kind of looking at the maternal and child cohorts where, eating habits are established at a very, very early age. And so, how are we going to look at, the long-term impact of that as well? So really just, I think most of it relies back to what resources are in the communities that are already existing that we can just, enhance not only for our participants, but for the general community as well. Next slide, please. Some of the program challenges that we faced while implementation are, limited access to cell service and internet. Because of Navajo Nation is such a vast area, there are different, locations where access to technology is limited or non-existent. And so we've had to work around complications from that, consistent data collection, because of, again, back to access to cell service and internet, we've tried to keep up communication on a consistent basis with our teams. And so with COVID, it was hard to meet with them in person, which was our primary way of interaction with them. And so, fortunately, we were able to identify a data platform that is consistent with, limitations of, remote areas. And so that's the ComCare platform. And so we've trained all of our teams to utilize that platform. So hopefully, in the next coming months, we can see how that comes into play and really if that improves our data collection practices. Timely voucher redemption, because our stores operate on, different schedules. It's hard to have them submit them like on a monthly basis and things like that. Some stores are very good at it, but some stores don't redeem enough, so they don't send them as frequently as we would like them to. But really, just working around with the stores has also been helpful. And my colleague Robert can talk a little bit more about that. And then personnel bandwidth, IHS and our teams, in general are facing barriers with personnel because there's, shortages of staffing, and then there's transitions that happen because of COVID. And so we've been trying to navigate around that, even prior to COVID. And so, turnover rates within our existing teams at the clinics. When one provider leaves, how do we ensure that, the next provider coming on board is familiar with the program and can pick up the program where the last person left off, things like that. We've had to take into consideration because we've had challenges, are still currently facing challenges with the continuity of the program as transitions happen. And then also, electronic systems that are compatible within our tribal communities. For example, we are trying to roll out an e-voucher card, much like the SNAP card or the WIC card, but we've had programmers and, vendors provide us with some options, but because of the limitations that we already face with technology and the magnitude of the stores, and they're smaller stores, so they can't really, their systems aren't compatible with like some of the larger stores. So we've really had to navigate through some of those challenges and remain, cognizant of what works for one team and what works for another team, which really essentially is one of the challenges. But it makes each program or each FVRx program that's operating in the clinic unique in one area as opposed to in another area. So it's had its ups and downs with the compatibility wise. Next slide, please. Okay, and then I will let my colleague Robert go ahead and talk a little bit more about the Healthy Navajo Stores Initiative.
Thanks, Kymie. My name is Robert Alsburg. For those who might be Navajo on the call, my clans are Toa Nan Sense, and the Cotton Bushes change, but after the national touching the I know we are running late on time, so next slide, please. I just want to talk about our Healthy Navajo Store Initiative. It works, with the FVRx program as well. And our side of the store is really just our aims are to increase the amounts of fruits and vegetables and healthy Navajo traditional foods in the stores throughout the nation. And right now, we are currently working with 29 HNSI stores that are located within New Mexico, Arizona, and Utah. Next slide, please. Here's a map, and essentially all the green dots are, stores that are HNSI and FVRx involved with COPE. You can see the red ones, and those are just the HNSI only stores, so they don't redeem vouchers. Also, you can see the H's. The purple H's are the larger health facilities, and the turquoise H's are the smaller like clinics. So you can kind of see there's where the health clinics are. We tend to have participating stores. Next slide, please. So how do we support the stores through COPE? We support them with technical assistance, such as like helping them with the store layout, just improving the flow or maybe the area and where they can find healthy foods, just really helping them make their choices in a quick way. We help the stores identify healthy and traditional foods to stock. We also provide trainings on how to increase the longevity of the food that they've purchased, and also how to kind of maximize their dollar in terms of handling the produce. And then more importantly, we really start to try honing in on how can the store build a relationship with the community or with ourselves or with other entities that may be within their local community. We also help in terms of promotional resources such as providing free displays, providing food, water demonstrations, marketing items like posters, shelf talkers, or anything that may be specific to the store ask. We'll try to develop that. Next slide. I'm just going to talk a little bit about what the program that we've done so far, and then just kind of maybe talk about the challenges here at the end real quick. But when COVID hit, essentially we had to change our programming, of course. And when that happened, we focused in on just providing a lot of PPE and like educational material to the stores, to the employees, in terms of helping them kind of get through those transitions, especially with the lockdowns that we've had here on Navajo Nation, and then also just the multi-layering of requirements or guidelines that they needed to adhere to. Next slide. Most recently, we're helping with GusNIP capacity building, an innovation fund grant where we're looking into helping 4 to 5 stores on the Navajo Nation and new refrigeration units. And, of course, the units will help increase the fruit and vegetable capacity of these stores, and also just allow for more like impulse buys. They're smaller refrigerators that can be closer to the cashier desk. Next slide. So going forward, we really want to expand, of course. We did lose a few stores due to COVID in the past 2 years. Right now, we're working on refresher trainings with the store employees, just kind of getting them up to date again with any changes that might have occurred in the past 2 years. And then also we're looking to onboard 5 or more stores to add on to our group of stores that we work with. Of the 29, I think what will help is really just what we're learning right now is how can we increase the community loyalty and investment for the stores? How can we get people to be more invested in the store itself? And how can we create that loyalty for them? Also, how can we increase the recognition and highlight the importance of supporting small stores on the Navajo Nation that's vast, as you can tell, with the maps. And it's really hard to get a unification going on, or to at least get some communication going on with the stores themselves. And because they are so far away from each other, they feel like they're alone a lot in terms of navigating, whether it might be business aspects with Navajo Nation or requirements with that, or just even the local government itself. And then finally, just remembering to ensure that there's always a positive interaction with the participants. The stores and the clinical sites and the participants are really miles away from each other if you think about it, but we're trying to focus on making sure that the end part of that experience through the education, receiving the vouchers, and then once they redeem it, ensure that that's positive so that they're able to have confidence in the program and also understand its convenience with that. Next slide. Okay, but I think just to kind of wrap up, the challenges we're working on right now is just working with corporate level stores, such as small gas stations that are corporate, and then also how do we support small stores in a different way. Thank you.
Hi, my name is Beth Tressler. I am a pharmacist by training, and I am the coordinator for the Yukon-Kuskokwim Health Corporation Diabetes Prevention and Control Department. This presentation was prepared with Amber Chung, who served as our outreach coordinator with the launch of our prescription program, and then Roger Lowe, who serves as our data entry specialist with the program. Next slide. So Yukon-Kuskokwim Health Corporation is a tribal organization. We serve 58 rural communities in Alaska, and each of our communities is home to a federally recognized tribe. The mission for Yukon-Kuskokwim Health Corporation is working together to achieve excellent health, with our vision being through Native self-determination and culturally relevant health systems, we strive to be the healthiest people. Next slide. So the 58 tribal communities that we serve are listed here on this map. The Yukon-Kuskokwim Delta is the orange area highlighted in Southwest Alaska. You can see that the area that YKHC serves is about the size of the state of Oregon. And then I have stars on the map representing each of the 12 communities that we are able to offer a prescription produce program in. Next slide, please. So before GusNIP existed and before we had the grant, we knew that there was a great need for fresh produce and healthier foods within our communities. And so about 4 years ago, we started a program where we partnered with a local farmer, Myers Farm, and allowed people throughout the entire community, any of our villages, to send in a form requesting produce each week. And then we translated those forms into a shipping label and a request to the farmer to fulfill a produce box. And you can see in the picture that is representative of some of the boxes that people received when we were offering this produce this way. Next slide, please. So this is just a graph a little bit about showing what happened before GusNIP. And so we started the program approximately July 1st of 2018. And to summarize the slide, The line shows that from July of 2018 until December of 2018, we had huge demand for boxes each week. It just grew as the time went on. And then unfortunately, we had to stop the program in December of that year because all of the produce boxes had to be shipped from Bethel, which is the hub for the region, out to any of the villages where people had requested a box from. And due to not supply chain, but just travel issues, oftentimes the produce was not getting shipped in a timely fashion and would freeze before it could get to the recipient. So we had to stop the program at that time. Next slide. So at the conclusion of that program, we collected surveys, and just one example of the response that we received from conducting the survey, there's 3 questions listed here. And the response for this one, on average, how much of the box did you use? And this recipient noted all. With the produce we received, we are trying different ways to prepare them, which is great. Do you feel that your household would continue to eat vegetables in the event that this produce program ended? The respondent said no, that they would not continue to eat vegetables because there isn't a variety out here and not as much as I had received from your program. The final response I included here was, do you feel that receiving these boxes improved you or your family's overall health? And the respondent said yes. Yes, a variety of fruits and vegetables have improved our cooking and eating habits. As the diabetes plate indicates, we need vegetables each day. Next slide. So from that very brief project that we conducted and the surveys that we collected, we knew that there was a need in the region. So fortunately, the GusNIP prescription produce grant was offered, and immediately with a tight turnaround, my team and I put an application together, and we were awarded a grant of $507,340 with a timeline for the project to run September 1st of 2019 through August 31st of 2022. So it's currently ongoing, and our long-term vision is to try to offer the program in more communities to be able to increase the value that can be redeemed with each voucher and increase education to the participants. I just want to stop and point out these 2 pictures here. And I failed to mention when we were looking at the map of the region that there are no roads that connect any of our communities. Bethel is the hub, but in order to get to Bethel, Alaska Airlines flies into Bethel 2 times a day. And then going out of Bethel to any of our remote communities, it's usually one of these smaller planes that you see below, either some type of caravan or a 172, but definitely small planes. And then the top picture is representative of our region as well, where you can see that there's a lot of water and small bits of land surrounded by that water. So again, none of our communities are connected by roads to Bethel or even Bethel outside of the region, which obviously comes with huge challenges when trying to grocery shop or obtain any kind of fresh fruit or vegetables. Next slide, please. So when writing the grant, we worked on eligibility requirements, and we concluded that participants needed to be 18 years of age or older, or have the involvement of a parent if there was an under 18 child identified as being in need. They had to have a qualifying diagnosis of either diabetes, prediabetes, or gestational diabetes. And then they also had to be living in one of our 12 participating communities. And that's because the communities had to have a store available for participants to purchase, to use to redeem their vouchers. And then the participants also had to be covered by Medicaid, which goes hand in hand with what Tim was talking about in terms of participants having to have SNAP benefits. Next slide, please. So some barriers to the program: location, infrastructure of the stores, and of course, COVID-19. So Bethel is the hub community. We made a lot of phone calls, sent a lot of letters out to eligible participants in the participating communities. But mail is slow. People don't always read the mail that they receive. They don't always answer the phone when we try to call. So it has been challenging to recruit people. Education, so finding ways to get education out to our participants has been a challenge, but we recently started including recipe cards and nutrition tips in our mailouts when we mail out the vouchers every few months to the participants. Data collection has been a bit of a challenge. We do an initial survey to sign people up, but then getting the follow-up survey back has been a bit challenging because our participants are spread out across the region. And then distribution of the vouchers and making sure that the stores are stocking foods that can be purchased with the vouchers has been a challenge. Infrastructure of the stores. So we started out, I think, with 8 villages, and then we were able to expand to 12 more villages a few months ago. Initially, the stores that we worked with were Alaska Commercial, which is kind of the main grocery store in the region, and they have a larger store in Bethel. And then we were fortunate to partner with a few village stores, but obviously working with village stores compared to a more commercial outfit. The commercial outfit like AC is more equipped to handle invoices and training and receipt of vouchers, whereas our more local village stores, a lot of the times we get handwritten receipts and have trouble even getting the smaller stores to send in the invoices for us to reimburse them for the purchases that are made with the vouchers. And then COVID-19 really put a damper on our plans. We had planned to travel out to all of our communities to host events in the stores and do some recipe demonstrations and just try and generate excitement and make sure that people knew about the program that we were offering. But with COVID-19, we were not able to travel and really do any of the in-store events that we had envisioned with our application. And this picture here calls out one method of travel that we can utilize in the wintertime. And we did have staff before COVID-19 travel out and do a little bit of education and community work via snow machine when it was cold and wintry in Bethel. Next slide. So how is our program designed? Like I said, we have 12 participating communities. We identified that approximately 40% of people diagnosed with diabetes in the region live amongst those 12 participating communities. We had hoped to increase collaboration with the city and tribal governments, with the community-based health clinics, as well as the community native stores. So we had intended to make sure that the tribal councils and the cities all knew about this program that we were offering. We wanted our health aides that are based in the community clinics to know about the program, to also kind of drum up business and make sure that eligible people knew about the program. And then, of course, working with the community native stores. Ideally, we would, partner with some of the smaller stores to help kind of build infrastructure and make sure that we're supporting the smaller stores. But at the same time, those types of stores have been challenging to work with. And then we offer paper vouchers that are in the amount of $45. Initially, we offered one $45 voucher per month and then provided 3 months worth of vouchers at a time. However, due to kind of the slowness of rolling out the program and some of the vouchers going unspent, we were able to increase the amount that we distribute, and each participant receives 3 $45 vouchers per month So 9 for every 3 months, and they have up to $135 to redeem each month. Next slide. So this slide 1 shows you what the actual voucher looks like. And in the middle, you can see the Yukon-Kuskokwim Health Corporation logo, and then it says Prescription Produce Program, $45. The vouchers have on it some useful information for the store. So the participants are able to purchase WIC approved, fresh, frozen, or canned fruits and vegetables. We went with WIC approved items because we knew that the stores were used to participating in WIC and would have a list of foods available to them that they could review if they weren't sure if an item was eligible for purchase under the prescription produce program. We put a participant ID that is only a number that would be identified by our program staff on the voucher, so that when we get the receipt back from the store, we'll know who redeemed it. And then we put valid dates on it so that they can only be used within a certain window. And then the rest of the slide shows you the varied ways that we receive invoices back from the stores. So the top left one is Alaska Commercial, like I mentioned. And as you can see, they obviously have a computer-based invoice system, and they send us a itemized list of what was purchased, and then the total amount that was due. And then it also includes the participant ID so that we know who to connect with for what was purchased. The bottom left picture shows a village store receipt that we'll get in the mail back from the stores. And they're just handwritten receipts, but it does tell you basically what was purchased and the amount spent. And then another one of our stores, the top right, shows you that they'll send us a copy of the receipt and the voucher that was used. And also highlighted on the voucher is, again, that it can be fresh, frozen, or canned fruits and vegetables. Our smaller stores and smaller villages don't often have a variety of fresh foods available. And so we didn't want to make that a barrier for participants. And so they are able to purchase frozen or canned items as well. Next slide. So part of our program includes data collection. We are a health corporation that has the grant, which allows us access to the participants' medical records. So we are able to track hemoglobin A1C, medication compliance, LDL and HDL, triglycerides, total cholesterol, weight, PHQ-9 scores or depression screening scores. We can track the number of emergency department visits that a participant has had, as well as if participants are not showing up for any of their scheduled appointments. And so we do have a research project associated with our program that we'll be publishing the information on at the completion. Next slide. So our current status is that we have approximately 118 active participants. We've had 26 people drop out. We've handed out 2,990 vouchers worth about $135,000. Our redemption rate is sitting pretty consistently at 43%, with $58,000 in invoices that we received back from our stores. Next slide. So just to conclude our program, ours looks a little bit different than COPE. It's pretty simple in terms of our setup and how we recruit people, but it's been a worthwhile project and something that I'm proud to say that we've been able to offer in our community. Thank you.
Thanks so much, Beth. Thanks, Kymie and Robert. We are very tight on time, and I think we had a few questions arise in the Q&A, but they were all answered, so that's good to know. And I will send out those questions and answers later on to the attendees, along with a recording of the webinar and some key takeaways. But just since we have a few minutes left, I'll go ahead and ask a question or two. So how did you promote, and this could go to either team, how did you promote your project? Was it social media, radio ads, newspaper? What was the most effective form of promotion? And I know some of you touched on this a bit, but we'd love to hear more, either COPE or YKHC.
For the COPE program specifically, we didn't really have a lot of like promotional ways to enrollment, just because we already have quite a few large number of interested participants. So it's mostly been done with just, the clinics, the word of mouth, and then them like a referral process. We didn't have to, really utilize like ads or anything like that. It was more of like internal recruitment.
Great. Anything on your side, Beth?
Yeah, ours was pretty similar. We knew who our target participants were and worked to contact them individually and invite them to participate.
Great. Another question we have was, what was the local approval process for your organization to get a nutrition incentive project started? Were there unexpected hurdles?
I'm not really sure. I think ours started in 2014, 2015, way before I started. So I imagine there were some approvals needed. I know we had to go through the IRB, but as far as the establishment of the program, I can't really speak to the historical context of it just because I wasn't here during that time. But I'm not sure if Katie, our program director, has maybe a little more information on what the approval process would look like for implementation. But I know we did have to get approval from the Navajo Nation government and our IRB internally.
Yeah, this is Katie Callahan from COPE as well. And I think the only thing that I'd add is that in the early years, when we were still kind of getting the program off the ground, that we did do presentations with kind of the agency councils. And so kind of the regional councils within Navajo Nation, if we were going to be working in those regions, and then also had approvals with, for example, the CEOs of maybe the IHS hospital or the Tribal Health Organization hospital. And as Kymie mentioned, have ongoing presentations to Navajo Nation IRB with the idea that all Navajo Nation or data is owned by Navajo Nation from the program at the conclusion of the program.
To get the grant application approved, we had to work with our senior leadership and make sure that they were on board with the goals of the program. And we did have to get IRB approval since we were doing a research component to our project. But it went pretty quickly and pretty fast because we were late getting notified on the application and had a tight turnaround time, but we made it happen.
Great. And with that, it looks like we're at time. This was a lot of information to go through. So, I wish we had some more time here, but we really appreciate YKHC and COPE for their presentations. They were fantastic. And thank you so much for the work you all do. As you can see, here are the emails for the different organizations that you can reach out to. And once the recording is ready, we'll send out a link to that along with a few Excel docs of questions and answers and things like that. And just so you know, at the end of this deck, which you'll have access to as well, there are the 2 RFAs posted, one for the nutrition incentive RFA and one for produce prescription. Again, please reach out to any of these organizations to ask any questions. We're happy to speak with you and help in whatever way we can. And thank you all so much for coming. IFAI, thank you so much for hosting this. It's been a pleasure, and we look forward to chatting with you all more. So everybody, have a great Monday, and we look forward to staying in touch.
Thanks, everyone.